due to a retinal tear like in a rhematogenous retinal detachment, or it can be due to a vitreous traction band pulling neurosensory retina like in a tractional RD, or it can be due to accumulation of fluid in the subretinal space due to a mass lesion or inflammatory mediators like in a exudative RD. And surgical management is usually indicated only in case of a rhematogenous or tractional detachment. And by fresh RD, I here mean only rhematogenous RD, because usually exudative and tractional RD happen over a long time. So our management will start with careful retinal examination to find all the retinal breaks, remove any traction on the retina, and create adhesions between the detached retina and underlying pigment epithelium. First by creating chorioretinal inflammation, sealing the breaks, and ensuring chorioretinal apposition till the scar formation happens with an optional drainage of subretinal fluid. So preoperatively, we do an indirect ophthalmoscopy with scleral depression or an ultra-wide field imaging to identify all the breaks, and we do the same intraoperatively with an indirect ophthalmoscopy if we are doing a scleral buckle, or with a microscope if we are doing a PPV. And link-off rules help in identification of the location of primary tear in case of a rhematogenous RD based on the SRF distribution. So for forming chorioretinal adhesions, we either freeze the healthy retina surrounding the breaks or apply laser to the healthy retina surrounding breaks to lead to scar formation. And to ensure the chorioretinal apposition, we provide tamponade either internally with intraocular gas, and the commonly used ones are SF6 and C3F8, which cause apposition of superiorly detached retina. And silicone oil can be used in case of giant tears or if there is extensive PVR. And external tamponade can be done with scleral bucklings, where we use silicone explants, which can be tires or bands or sponges, to reattach the retina. And SRF drainage is optional, and it can be done by internal retinotomy if you are doing a PPV, or external sclerotomy if you are doing a scleral buckling. Coming to the choice of surgery, in a cooperative patient who has superiorly located single break and no changes of proliferation, we can go for a pneumatic retinopexy, while a young phakic patient with anteriorly located break is an ideal candidate for scleral buckle. In a patient with wide bullous RD and marked traction and tears in multiple quadrants, we can go for a pars plana vitrectomy. For pneumatic retinopexy, the retinopexy can be done by cryotherapy or by laser photocoagulation, and paracentesis is done before gas injection. And after injection, we ask the patient to maintain a particular head position so that the break is in the superiormost position. Here we see a patient with superior RD treated with pneumatic retinopexy with attached retina 3 weeks post-operatively. And scleral buckle, we do a conjunctival peritomy and we give bridle sutures for all the recti muscles. And intraoperatively, we do an indirect ophthalmoscopy, identify all the breaks and apply cryotherapy for them. Then we give partial thickness scleral sutures for fixing the buccal elements. After which we do a external sclerotomy for SRF drainage. Then we adjust the scleral sutures for optimal buckling effects. And this is a patient treated with scleral buckling showing attached retina post-operatively. And pars plana vitrectomy, after putting the pars plana ports, we start with a core vitrectomy followed by peripheral vitrectomy. Then drainage of subretinal fluid can be done by fluid air exchange, following which after the retina is reopposed, endophotocoagulation is done to seal the breaks, and post-operatively we can give a gas or silicone oil tamponade. I hope you guys understood something. Thank you.
Good one. And next team, please be ready with your PPT on this side.
So if you have done a vitrectomy with a gas for a patient who has come from, say, Canada, because Punjab mein there are so many people coming. So what will you advise him?
Usually air travel shouldn't be done immediately post-operatively in the patient.
So how long will you tell them to stop? Not
5 days usually.
5 days should be enough.
Na team.
And why?
Usually the
Morias blaster. Huh?
if we are injecting SF6, it takes around 2 to 3 weeks to get absorbed, and if we are giving CTF,
Answer in the mic, hai, so that other students can
around
also
6
learn.
weeks it will take to be completely absorbed. But for maintaining the position, usually we ask them to maintain the particular position for 5 days. So at least for 2 if we are giving intraocular gas in high amplitude, because the pressure will be low.
So what will happen to the gas? point is, would you advise travel or not? Air travel.
Why
before
are you
putting gas?
stopping them to travel by air?
It expands in low pressure if we are going to higher altitude, and it will increase the intraocular pressure.
Yes, yes, yes.
Thank you.
Good.
What happened to
So
the
next
packets of
speaker.
chips there? Seen packets of chips here. Huh? We go to late.
Thank you.
Thank you, sir.